Good afternoon, everyone. We'll get started in 1 minute. I want to welcome you to our August Community Roundtable. It's my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies and to ensure that we have the appropriate level of collaboration and information sharing here on the Da Vinci Project. We're actually really grateful for your participation in this August Community Roundtable, Da Vinci's monthly education webinar. So today's agenda starts with a limited set of program updates that I'm going to walk you through, and we're going to spend the bulk of our time together focused on prior authorizations. I'm really excited about today's presenters. We have 3 folks representing 2 of HL7's FHIR accelerators, the Da Vinci Project and CodeX. The team is going to talk today about Da Vinci Prior Authorization Implementation Guides, or IGs, and we've been referenced, that have been referenced in federal proposed interoperability regulations. We'll first learn about the value proposition and Da Vinci's implementation efforts underway, including Da Vinci's HIPAA exception with some latest metrics. Then we'll have an overview of CodeX as an accelerator, the scope and how its members are leveraging, really, I think, lifting and sort of taking advantage of the work of the Da Vinci IGs to tackle prior authorization challenges, specifically in the oncology space, really with the goal to improve the care journey for cancer patients by expanding prior authorizations via automation. Today's presenters include Ellen Anderson, who's an enterprise architect from Evernorth, Kirk Anderson, who's the Vice President and Chief Technology Officer, also my chair for the Da Vinci Steering Committee, and Cambia Health Solutions. And then Sue Chen, who's a doc and the CodeX Program Manager and the Clinical Science Principal at MITRE Corporation. We've included time. Our goal is to include time at the end for questions, but definitely feel free to use the Q&A box throughout the day, and we will make sure that, as available or as it makes sense, we'll respond to those questions in turn. You can look at that. You can see that in your GoToWebinar function in the main menu. So let's go ahead and dive in. Just a reminder, GoToWebinar has been a lot of fun for us today. We will be posting a recording of today's webinar and the slides on Da Vinci's video presentation page on Confluence. Confluence is the home where we save all of our information. Da Vinci's communication lead, Leslie Emeris, will be posting the links in the chat box, other relevant links as we go through the day so that you can get to that information. Your lines are muted to aid in the recording of the quality. If you have an audio issue, we suggest dropping and rejoining the webinar and or dialing in if that doesn't work for you. Just a reminder for folks, we do hold these community roundtables monthly, and our next one is scheduled for September 27th. We're actually still talking about what our topic is going to be. We're leaning towards our patient cost transparency team giving an update, but I think we've got a few other things in the mix to see if we can do that. But these, again, we really use this forum to be able to get out good quality updates and progress points in the program. I'd also like to highlight a couple other events that are happening that I think are going to be of interest to this audience. HL7 is actually holding the first ever synthetic data event, and it's actually next week. And this is something we'd love for you to share with folks in your organization that are grappling with the ability of how we create realistic synthetic data out in the industry. And the next set of events, we do have an update coming, HL7 FHIR Connectathon, for those who you are implementing and building to the both the Da Vinci specs and other specs happening in HL7 FHIR. So we invite you to join us. It's also HL7's plenary in addition to the work group, and there's a focus on artificial intelligence in the first couple days of the meeting. And we always like to do a shout out. We're super excited that the ONC annual meeting for their technology sort of stream of work is actually back to in person for the first time since the pandemic. There's a link to registration. Leslie will drop it in the link. This is a really great place to get hands-on updated information on where interoperability is from an industry perspective. And it's always fantastic to see a strong representation from the FHIR community at those events. So with that, I'm gonna flip over and talk a little bit about where we are from a Da Vinci program perspective. We are always continually updating and evolving the roadmap for Da Vinci. And just for context, this provides basically an overview of the discrete individual implementation guides and the work related to the ballot cycles And we really put this out to help both the HL7 work groups, but also you and your individual organizations as you think about resource planning and where you need to have financial or human capital to be able to put resources around picking these guides up and using them. And our goal is really to create a single view for people to use from a planning perspective, but all feedback and changes are welcome if you think there's something that we can do to make this more usable for you out in the world. And then the last point that I would make here before we go is there's just a couple key updates. One is that we are dealing with sort of the reality of the world of getting to publication, and we have moved CRD, GTRF, PAS, and PDEX to a likely September publication. Each of those individual guides is sort of in its own path towards publication. And we're actually really excited that we're pushing for both ATR, member attribution, and risk adjustment, both that are at the STU2 level as well, to be able to go to publication in early October. So keep paying attention. We'll do updates on the listserv, and we will keep moving forward and bringing those updates out to you. And then just a little bit of a deeper dive around the use cases, and just to give you guys insight from a planning perspective, PDEX is advancing to the STU2 version to published, and they're also starting to gather requirements for future enhancements to incorporate. There's a number of sort of draft content pieces in this guide, and this will take into account feedback that's really happened throughout the ballot reconciliation process, and from end users picking up the guides and using them since the last ballot cycle. And so we're really being, I think, bullish on getting that draft content out there so folks can get their eyeballs on it. The next is PCT. The team is wrapping up the self-pay patient scenario, and the team is changing their meeting date. So we want to get that out there. As of 9/6, they'll be meeting on Wednesdays at noon Eastern time, and refer to the HL7 calendar to get that on your recurring schedule. And then clinical data exchange, we continue to look on expanding the number of testers participating in the Connectathons, and we're leveraging the CodeX inside of some of the prior auth workflows, but we're still looking for additional users around using the guide for any of the different clinical data purposes that are out there. And we're really looking at people picking up CodeX, not just that are using the FHIR resources, but also people that are using it to leverage, where out in industry you're using CCDAs or PDFs or text files. We're really looking for samples and examples of places where you want to get to more codified data. So if you haven't already joined CodeX, or the right team members join CodeX, that would be helpful. And then the last two updates, notifications, there's a use case team that is only meeting quarterly now. And we actually have moved that meeting to 8:30, not to 9/6, just for scheduling purposes. We wanted to get ahead of the long weekend. And so if you're going to come to notifications this quarter, and there is some activity there around adding some feature functionality to support direct messaging, that we'd love to hear from the community and their thoughts on that matter. And then value-based performing, this is actually on track to go to its first ballot. And so we did a testing, an informal testing event this summer, and it will be at Connectathon. So if you haven't picked up and started to use the value-based performance reporting with your folks that own contracts and value-based data sharing at the contract level inside your organization, please get those folks involved. We have a really strong community pushing forward, I think, at pretty rapid pace with that use cases. And then the last piece, building on standards, takes a village. And we really are looking for additional participation and additional SMEs, both on the provider and the payer side, across all of these use cases. As we mentioned before, expanding the examples for CodeX, those calls happen at 2 o'clock on Wednesdays. PCT, diving into the next phase with good faith estimates, and that call is starting to move to Wednesdays. Risk adjustment, we are in ballot reconciliation. Those calls happen at Thursday at 3. PDEX and PlanNet, we're actually the second Friday of each month for PDEX and formulary are starting to use one of our PDEX calls each month versus adding another call to the schedule. So if you have tracker items, or if you're a feature or functionality that you want added to either PlanNet or formulary, please come to the appropriate meetings or send your SPEs to those meetings. And as always, we're always looking for people to come and test a Connectathon. Just a reminder, this Connectathon is in person. The January Connectathon is actually virtual. And if you don't have the information, we always keep an active use case schedule up and live for you to get to all of the right parts of the use case that you might be interested in. So with that, I'm just going to pause and see if there's any immediate questions for this portion. And if not, I'm going to flip over and start the dive into the meat of today's conversation around prior authorization. Okay, I'm going to go ahead and dive in. Thank you again, Kirk. I am so excited to have you here and to be able to share an update on what's happening from a burden reduction perspective and the progress that with your Cambia hat on, you can share with the audience. So with that, I'm going to actually hand over control so Kirk can drive his own slides. Kirk, let me know if you got that.
All right, let me get that teed up. If you could let me know when you're seeing my slide, that'd be great.
You're good. I can see the very header on your first slide.
Excellent. All right, well, good afternoon, everyone. Really excited about the opportunity today to do a couple of things. Number one, share some of the results from some real world production utilization of the Vinci prior authorization use cases, but also to be joined here today by Ellen and Sue to show how the work that we are driving in Vinci is being picked up by other HL7 accelerators like CodeX, taking prior authorization work as an example and applying that into the oncology space. But before we get into all of that, first, just a little bit of level setting slide on the big picture problem that all of us are working on together within the context of Vinci to solve. It's been estimated that the lack of standard APIs in healthcare contributes to $30 billion in waste. That's just money spent on inefficient ways data moves around the healthcare system. And those of us in Vinci know that a big chunk of that 30 billion is in the way payers and providers are trying the best that they can to collaborate in the absence of standard APIs. That manifests itself in many different ways. If you think about those use cases where a provider is trying to provide care to an individual patient, doing that today without the benefit of APIs results in the following. We've got payers, as you can see here, listed on the right side with their internal systems like claims processing systems and prior auth systems, et cetera, et cetera. And the best that we can do today without APIs is to surface this technology through UIs, through user interfaces, web portals. And payers typically have a lot of them. They may have a prior auth portal. We want the provider to go there to do a prior auth. They may have a care gap portal. You want to see the open care gaps for your patient? Log into this web portal for care gaps, et cetera, et cetera. When you multiply that by the 100, sometimes 200 or so payers that providers have to navigate, you get a sense as to why providers see this as a significant burden. Payer portalitis is the term that I learned having worked within Vinci. That's what the providers are really focused on us trying to solve with APIs. The reason they don't like it is pretty understandable. Number one, every time they have to leave their native EHR workflows to navigate these different portals, we're already having to introduce manual operations. These experiences as they navigate all these portals are disjointed. And when data needs to be exchanged, for example, in support of a prior authorization, when we're in the portals world, we need humans, whether it's the provider or the back office clinical staff, to upload that data manually. Not optimal. The other types of use cases, though, beyond these provider in the middle use cases, are the bulk exchanges of data, population health type exchanges of data, where today, without the benefit of APIs, we do everything we can. And that includes chart chasing and paying third parties to sit in the middle of the payer and the provider and try to make sense of the data. We do ad hoc data extracts. All of this is a main contributor to the fact that we have an inconsistency in how this data is structured, very difficult to automate it, et cetera. And so those use cases like data exchange for quality measures are ones that are also ripe for transformation using FHIR APIs. All right, so if that's the problem we're trying to solve, the solution, high level, API-powered healthcare. With FHIR, we now have that open, secure, standardized API to bring to bear on these problems. We need providers to have the FHIR API capabilities. We need the payers to have them. And then what we do in DaVinci is bring our collective, collaborative energy into providing the use cases to do this work with FHIR APIs. That means the digital front door to a payer in the future is the provider's EMR. No more web portals, no more portalitis. It means the exchange of data can be automated because we are using APIs and we are able to access data in a consistent, standard, repeatable way. We're always going to want to partner with vendors and specialists in helping us achieve our objectives. We can do that by bringing those vendors along into this FHIR ecosystem. We've done that in our prior auth work, and I'll talk about that here in a second. But this, again, applies not only to those use cases like prior auth that are patient equals, one patient specific, but also population health exchanges. All right, so now, with that kind of broader context, let's zero in on prior auth specifically. So today, when we're not receiving faxes, because unfortunately that happens a lot too, the state of the art that we've had really to offer providers are these portals. And again, not ideal for a number of reasons. It brings the providers out of their EHR workflow. It means that the provider side here needs to be able to track down the clinical data that is often required in support of a prior auth request. They're doing that manually. They're looking for it in their EHRs and then manually uploading it to the payers. Whoops. Typically, what gets uploaded there on the first try is not exactly what's necessary to process the prior auth. We may not get the specific labs that are needed, or we get way more data than we need as payers from the providers because they're not sure and they kind of throw the kitchen sink over the wall for the payer to sort through. This typically ends up in a lot of back and forth, people calling each other on the phone to figure out how we move the needle forward, and ultimately leading to delays. And this is really the reason why we want to fix this. It's the patients that we all serve that end up waiting days for a resolution to a prior auth request, delaying necessary care. So that's the problem, and the DaVinci solution to that are our DaVinci use cases. As you guys know, we have 3 of them within the umbrella of burden reduction, coverage requirements discovery, documentation templates and rules, and prior authorization support. At a high level, coverage requirements discovery is about asking the payer, is this patient your member? Do they have coverage? And is a prior auth even required for this particular course of care that I am prescribing as the provider? Documentation templates and rules is the use case that allows payers to apply their care guidelines in an automated way to those prior auth decision requests. And then finally, prior authorization support kind of does a couple of things. It allows us to complete the cycle and communicate the results back to the provider, but it also supports our ability to do this work in a way that still takes advantage of or uses the HIPAA mandated X12-278 response. Now, those of us in Da Vinci are familiar with the fact that CMS, in an effort to support innovation in prior auth, provided an exception for Da Vinci members to be able to skip this X12-278 sandwich, as we call it, right? Because those of us who understand the benefits of APIs versus document exchange understand that it's really not necessary if you have FHIR APIs on both sides exchanging data to drop it into an X12 document just for the purposes of complying with HIPAA. So we were given this exception to prove that it could work without the X12. And of course, we've done that. So the solution that I'm about to share the results of was done using that exception and done in a purely FHIR to FHIR manner without any X12 in the mix. All right, so as I mentioned, we take the Da Vinci approach here. We're using those Da Vinci use cases. We've got FHIR API capabilities on both sides. In our case, with prior auth, we're creating that FHIR API capability on the provider side by using a smart app. But this allows us to achieve some of those high-level objectives. Now the provider's EHR, in the example that I'll share today, that's Epic. That's the digital front door to the payer. Provider doesn't leave Epic to process prior auths. They don't go to a web portal. Secondly, and this is probably the most important and greatest leap forward in all of this, is no more guessing on the provider side as to what clinical data is needed to get the prior auth process. The solution is able to pull that data automatically out of the EHR. It's matching up the clinical guidelines with what's available inside the EHR and presenting that to the provider so that they can verify it, double check it, make sure it's what they want to send, all before they click go and the data is exchanged. This means on the payer side, much less time wasted sorting through the wrong data, much less time wasted having to call the provider and say, hey, you forgot to send this lab or that whatever data element is needed. And finally, most exciting, reduces the patient wait time. So prior authorizations can typically take days and days. And we know, and we've now shown with real patients and real providers that we can do this in seconds most of the time. So let's look at some of the actual results. Now, the work that we have done here went in production last October. It was a collaboration between two Da Vinci members, Cambia Health Solutions, the company I work for, and more specifically, its insurance business, Regence, partnered up with MultiCare, and also our vendor partner, MCG, which is who Regence uses to deliver those care guidelines. So how have we done in reducing that provider burden of the time it takes to just submit the prior auth? Well, these are the results, actually outdated. They're even better now, but Anna Taylor's our Da Vinci Steering Committee member, and she's our partner over there at MultiCare in this work. For the MultiCare folks to process prior auths without the benefit of Da Vinci, they can get through about 3 to 5. This is just the submitting of them. And Anna will tell you, they literally have a whole floor of humans. That's their job, working prior auth queues across 200 different payers. When they use the Da Vinci solution, they get through 10 to 12 in an hour versus 3 to 5 in an hour And Anna was telling me the other day, this now that they're even more familiar with the process, this is closer to 13 to 15 in an hour. So great example of reducing provider burden. The second thing we really wanted to improve upon was improving the time it takes to process that prior auth once submitted. Here are those results. So we processed in production now almost 1,400 prior authorizations with multi-care. 89% of the time, we are giving the answer in real time, i.e. within seconds from the PA being submitted. Much of that is occurring only by using that coverage requirements discovery use case. When a prior auth isn't required, which happens a lot, we're turning that decision or that answer around immediately. This allows the provider to move on to the next steps, to scheduling or whatever it may be. Even when prior auth is required, we're automating the response. We're processing all those complicated care guideline rules, and we're turning around an immediate response another portion of that time. So if you total it all up, 89% real-time response is really exciting for all of us. All right, that's the end of my slides today. Just kind of a focus on how we're using prior auth in production. And now excited to, I think I'm turning it back to you, Jocelyn. Tell me if
You
not.
are. Weirdly,
Okay,
I'm
great.
taking control
So back
again.
to you.
Yeah.
Thank you.
Hold on
Thanks,
one
everyone.
second. Okay, let's see if by any miracle I managed to share the right screen. So if I can get one of you guys, Sue, are you on screen? Are you on off mute?
Yep.
Awesome.
You're on the right screen.
Awesome, great. So super excited to have Sue Chen give an update. Kirk and Sue actually presented a version of this presentation with earlier findings back at the HL7 Work Group Meeting Plus this May, and we had really positive feedback from the audience. And Sue is going to lay out basically sort of the what is and how CodeX works, and then she'll do a handoff to Ellen when she's done.
All right, thanks, Jocelyn. So we did give a shared presentation earlier, just actually only a few months ago at the May HL7 work group meetings, but I have to say, Kirk and Jocelyn, it is really exciting to hear about not only, it was exciting to hear about it then, but it's really exciting to see the further developments now. So we're excited at CodeX because as a sister accelerator, a sister HL7 accelerator, what we are doing specifically in prior auth is further leveraging the Vinci progress to explore prior authorization further, specifically in complex health areas such as cancer. So key takeaways for this presentation here is just that for all involved, regardless, not only in the area of prior authorization for general purposes, but for health data exchange at large, the time for FHIR and health interoperability, it really is now. And even in areas where there hasn't been significant federal onus or mandates, the traction and progress is real. And lastly, the secret sauce to addressing these key data sharing pain points and getting this progress done, it's really the community and the collaboration, not only within these accelerators, but across accelerators, across work groups, across this interoperability FHIR area at large. So I just wanted to give a thank you and shout out to community leader champions like Cambia, like Evernorth, where we're really able to, with support from this kind of community, push forward to alleviate like long-standing burdens and challenges and use cases, such as in prior authorization in cancer. So the question really for me this year has been, how real is this progress? And so I just want to note that about a year ago, if you had asked me, so for CodeX, is there really adoption of CodeX FHIR standards for routine use, for vendor adoption, or for CodeX initiatives that have demonstrated real-world takeaways? Have we demonstrated yet real-world takeaways or early impacts to patient care or research? And so if you asked any of those questions to me a year ago, we would have had to answer no. But just a year later, we get to say yes. So in doing so, let's explain what CodeX is, how we're doing this, and then highlight our prior and authorization and cancer use case. So this is the first slide. So first, explaining what is CodeX. So as CodeX, we are an HL7 FHIR accelerator, and we're really focused on advancing data standards in the area of complex health. And what we're doing here so that we can represent diseases like cancer and share about cancer and communicate to represent that true picture of complex cancer disease across healthcare so that all of us as patients, we can have the care and research journeys that we deserve and really should expect. Next slide. So CodeX began with a focus on cancer and radiation oncology, and now we've expanded to other clinical, complex clinical terminology areas, new growth areas such as cardiovascular health and genomics. Next slide. So what we're really trying to do is advance data sharing for complex health diseases. And so in doing so, we're advancing the development and doing implementation-focused initiatives around clinical terminology standards, such as what M-code, what you see here, which is a FHIR data standard for cancer. So let's look at this in reflection of a patient I saw not too long ago, say patient M. So M is about 70 years old, around the same age as my dad. They have prostate cancer that is spread with metastasis to the bone. And so to represent M's prostate cancer with the level of detail really needed to guide research and treatment options for M, details such as cancer stage or related genomic biomarkers, we really need to represent that level of granularity of detail, data standards like M-code. And you can kind of extrapolate here beyond cancer when you think about other disease processes, such as cardiovascular disease, or maybe more specific diseases, dementia, diabetes, where you would need similar level of granularity of other details related to that disease to truly represent that patient's health. Next slide. So at CodeX, our strategy is really to begin with the end in mind to drive adoption and implementation success at the point of care. So our end mission here, it's not just the development of FHIR standards, but really advancing these standards to improve, transform real-world health processes and outcomes. So in other words, what might this mean to you if you're like that patient that I mentioned earlier, say patient M? So if you're patient M with prostate cancer that is spread to the bone, and you now need prior authorization for radiation treatment, well, usually when you go to your care, you spend a lot of time, right, catching your doctor up with what's been going on or re-explaining what another doctor or another specialist has done. But with cancer, what these FHIR standards can do, like M-code, they allow us to speak via a common lingua franca or common language to support all parts of a patient's care journey, including the care you receive or even how you communicate from patient, provider to payer to get a treatment approved for payment by insurance. Without these data standards, it's pretty hard to share this important health information, right? How many folks here on the line have experienced this? I think we've all have in frustration or delays in either trying to get medical records from one doctor to another or struggling with ensuring that needed information is getting to our insurance to get treatments approved for payment. So these are the kind of struggles that we hope to alleviate by automating a world where FHIR standards really enable us to not only do the payer and value-based care transactions, but allow us to leverage things like M-code to speak about cancer, genomics, vascular health across the healthcare ecosystem. And what we're really hoping is that in doing so, that patients can focus on their health and not the process of managing health data transactions. Next slide, please. So this is a slide to just show why the time for FHIR is now. And so at the start of 2023, significant FHIR interoperability rules across the from federal agencies have really dramatically stepped up the floor of support, kind of like Kirk had discussed, really mandating core health data exchange via FHIR API. Next slide. And so in CodeX, we're levering off of that floor of support. So other areas of accelerator domain areas, such as those for value-based care transactions, for transactions related to the social determinants of health, there's more direct federal support for requiring or pushing, promoting that healthcare data exchange. In the area of complex disease, that's been more gradual to develop. And so any progress made with CodeX has really been where federal onus and mandate has not directly applied. And so we've really engaged our community to successfully garner voluntary buy-in de facto adoption. And we've been able to now point to that where we were not able to a year ago with a growing real world footprint. And so what that has meant is that cancer FHIR standards, they're now adopted by the largest EHR vendor in the US acute care space and available as of their November 2022 release version. In radiation oncology, those standards are in production or on release roadmaps for specialty EHR platforms, which actually support greater than 80% of North American health sites. And then use of CodeX related FHIR standards for active, for routine care are actually active or being rolled out, either domestically at health sites such as Mayo or internationally at certain health sites in Brazil and Germany. So that's been really exciting to watch. Next slide. So our membership has really been growing rapidly. It's been greater than 80% this year and really represents varied perspectives across healthcare. It's these folks, it's their real world vision, their expertise that it's really steering our course. The work that we do is really done with these stakeholders, their thought leadership, in-kind expertise, in-kind resourcing, frontline expertise, and really executing and designing CodeX phased use case pilot soup to nuts. And therefore, like all the work we do, it's sustainable, it's consensus driven, and real world stress tested. And we do this so that any progress we make really has the robustness and maturity needed to fly in actual healthcare environments. Next slide, please. So similar to this Vinci roundtable, at CodeX, we also socialize and champion the work that we do in complex health domains on community, public community calls. We call these CodeX community of practice calls. So if you're interested, we encourage you to join our calls and learn more about what we do beyond what you hear today. Next slide. And we leverage our member community and the broader public community to successfully engage and launch use case pilots. So what we've done here is all the work we do is implementation focused in these use case pilots. They involve leveraging FHIR standards, not only at the health sites, but in industry, public health research, or whatever other platforms needed to develop and validate workflows that are needed for targeted use cases. These are targeted use cases that span research, registry reporting, patient care management, etc. I wanted to highlight where Da Vinci FHIR standards are leveraged. They're leveraged not only in our prior authorization for cancer use case, but also in our risk evaluation and mitigation strategies use case. That's the third use case down on the right. This is in relation to an FDA program that is really designed to safely monitor and dispense medications with high risk of adverse events. And so I find that really exciting in addition to the prior authorization use case where we are now leveraging Da Vinci standards and testing them out for needs across the healthcare space, even where the Da Vinci standards had not originally been designed for. Next slide, please. So in our prior authorization for cancer use case, one of the key questions here that we are asking is it possible to leverage FHIR standards to automate prior authorization so that at least 80% of them do not need manual checks? We're in the regards to the complex area of cancer. And in doing so, can we reduce burden? Can we reduce delays so that patients have more timely access to care? So Ellen will be speaking more on this use case next, but I did want to highlight here, initially, the focus here is for patients like the patient M that I mentioned, who will need radiation therapy for prostate cancer. Next slide. In doing so, and this is the roadmap for this use case pilot, I won't go into great detail, but I did want to highlight, we've already finished proof of concept 2.0 here. So already validated with synthetic patient data, testing end-to-end connectivity across the different folks for the anticipated pilot. And the end pilot goal is going to be in spring, April of 2024. And like all CodeX use case pilots, the primary goals here are, whenever possible, to be able to facilitate a phased development cycle that really, in the end, involves live patients, in this case, live patient data and clinical data with actual production environments at the table. And so with these real world requirements at play, we are really stress testing what these FHIR standards can do in clinical spaces with significant learnings and takeaways developed accordingly. Next slide. And so this has really translated into a snowball effect with increased momentum and interest, not only from industry, but as of more recently, increased federal agency interest. So wanted to highlight that we have NCI, FDA, CDC as active CodeX members, with FDA and CDC having championed key CodeX use cases other than prior auth. And then what this is translating to is also increased interest that is now for the first time really leading to developments by federal agencies due to the bidirectional feedback that they're getting from being involved in our use cases, or either through active participation or with relation to prior auth or quality measures through listening sessions. On prior auth in particular, we have been having listening sessions over the course of the summer with CMS, ONC, to really share some of the early observations and takeaways from the work that we have already done so far. It's these kind of engagement forums that have really led to development, not only with prior authorization, but also with our quality measures and radiation therapy use cases that have led to call outs by ONC in the USCDI Plus quality data element list. So with USCDI Plus being an expedited track to help support what will be mandated federal health data exchange in response to what federal agencies may need specifically for health data reporting or use. And then as a result of some of the work done in this space with the folks at the table in prior auth and quality measures, they've also had a recent call out by CMS just a month or two ago in the Enhancing Oncology Payment Model, where CMS has noted that the FHIR standard for cancer M code is now pointed to for data submissions for this payment model. So that's all translated to, in the end, also increasing impetus with ONC calling out to now USCDI Plus in general for cancer overall, like what is needed now for federal agencies expediting the need for health data exchange, which should be required for cancer. Next slide, please. So I hope that you can see how this momentum is really built up, and it's really core to this has been the development and the really amazing progress made by our prior authorization community. So I'm going to pass this over to Ellen now so that you can hear some of the great work that's being done there and hear more in detail. But I just wanted to keep this slide in there so you can follow up if you're interested. Please reach out to us about anything you've heard today about CodeX, about prior auth. We'd love to connect further with you if not able to answer on this session. And now over to you, Ellen.
Hey, thank you, Sue. And just real quick check, did the presenter change go through successfully?
Yep, Ellen, you're good to go and you're on the right screen.
All right, thank you. So I'm going to start off with a little bit of a repeat of what Kirk did and go through current state and the awkwardness of it, and then talk you through the future state. So currently a clinician and the patient would agree on some sort of treatment, and the patient would probably leave the oncologist's office really not sure if that treatment was going to get paid. In the meantime, the clinician would enter the treatment plan into their EMR. The clinician would then go to their office staff to say, hey, can you submit a prior auth request for this? And again, this is all after the patient already left. The order is then submitted by the office staff, and they go to this portal that Kirk was talking about, but they might not have all the info that the payer is asking for on that portal, so it doesn't get approved. The office staff then has to go back to consult with the clinician again. This can happen multiple times. It could be interrupting the clinician's appointment with somebody else in the process. And they can't reach an approval status, so then it gets pended for the dreaded peer-to-peer review, which I know everyone hates. The peer-to-peer review might come back and say, oh, well, you didn't answer this question wasn't answered correctly, or you didn't, I didn't know that I had this option. The clinician might say, I didn't know I had that option. So after the peer-to-peer, they come to an agreement on a treatment plan, and now the clinician has to go back to the patient to discuss the adjusted treatment plan, and then the clinician has to go back into the EMR to adjust the order. So the process is tedious, iterative, and just not great. So we want to shift left is what we're calling this process. And in a shift left scenario, the clinician and patient have an initial review for their treatment options together during the appointment. The Smart on FHIR app through the Vinci Implementation Guides is then launched while the patient's sitting there in their consult. The clinician launches this app and gets information from the payer through the app, either using AI/ML or some pathway rules to execute against the data that's gathered from the EMR. And the payer is then asking the clinician for any missing data that was not able to be answered through the EMR extraction. And that communication can start either through an order select. In our pilot, we're using an order select because we're trying to avoid having the clinician make an EMR entry of the order that they then have to go in and change. We are allowing for the order submit to do the same thing with an alternate recommendation that would come back. But the order select process would be a way for the payable treatments to be offered before the clinician actually puts the order into the system in the first place through kind of a clinical decision support process. And this is especially useful in these complex disease states like cancer because the guidelines change very fast. And this is a way for the clinician to have some confidence that the guidelines that are offered through the Smart on FHIR app are the most current. And in the future state, the price transparency would be a good place to put this in, especially if you're sitting there with your patient. You could say, well, treatment A is going to cost you this much out of pocket, but treatment B is more effective and it might cost you a little more, or vice versa. So all that can be in that Smart on FHIR app in that consultation. And then the order is approved. The payer's records has that on file as approved, and it's expedited with fewer touch points, and sometimes even before the patient leaves the office. And this is very much in line with what Kirk was saying earlier. There is some thought that in the future, that whole regimen, because the prior auth in a cancer regimen could be multiple CPT codes. It could be a mixture in chemotherapy of medical and pharmacy drugs, as well as medical procedures. It could include images for monitoring tumor sizes. That all can be then entered into the EMR through the Smart on FHIR app. So that this is a proactive, transparent, less tedious process. So the project updates to our oncology process is we've moved to execution phase originally in November of 2022. There was a multi-phase collaborative approach for the live pilot. We have weekly calls, alternating member calls and technical groups. So every other week there's all the members of CodeX meet, and then the alternating weeks, the group of technical people that are working on the pilot meet together to do more technical solves. The Da Vinci CRD DTR PIRAS specification guides that supplement M-code data are, we have people participating in all of those calls. We have test scenarios and data defined, and we are now inserting clinical treatment recommendation steps into the workflow at order select. Oh, and I hit the wrong button. Sorry about that. So the PA in oncology use case scenarios are, we're starting with prostate cancer in a radiation therapy modality. This is intended to then move next into breast cancer once we get successful pilot with prostate cancer, and then we would move, after that, we would move into medical oncology, chemotherapy. But the data availability as referenced is unique to this pilot and the pilot partners, and I have a slide coming up with some information on the data availability. To move forward at scale, additional EHR capabilities are going to be developed and released. We have Varian is our radiation therapy EHR partner, and they have some release schedules to get their US CDI version in their FHIR server up to the level that we need. Here's the test scenario data elements that we need for prostate cancer. The green dot shows that they're available, red dot shows it's currently not available, and I say currently. But in an Evernorth situation, and this would be true for any prior auth orchestration vendor, we've discovered that in the original US CDI versions, the member ID and insurance carrier information was not available. And that was very important to an outfit like Evernorth and obviously someone like Multicare in Kirk's example, they would be interested in that too. The patient demographics are there, place of service, the ordering physician NPI, the caller submitter name would be your EMR user. The method of contact would obviously be EHR. Some of the site elements in oncology, we are getting the request from the site, but there will be future use cases where we might not be. There might be a referring provider, and we found that in that situation, the site NPI and alternate ID are not currently available. The clinical data elements that we're using for the prostate cancer, you can see the major data elements that are missing are things like T stage and M stage and Gleason score. But anyway, you could see that these are all data elements that are being added through the work of MCode and through the work that Sue was talking about earlier. So our test scenarios that we're working through is the round one is your happy path testing, where we have all the data elements available, not just in that list before, but in the clinical guideline pathway. We're able to get all the data out of the EMR without having to ask a question of the clinician. The approvable treatment regimen is selected by the clinician and it's auto-approved real time. The round two is where we have the adaptive questionnaire testing, where there might be some demographic data missing, there might be some clinical data missing. So this would require user data entry in the clinician workflow, which we want to keep to a minimal because we are asking for clinician participation, which is going to be new, and we don't want to be cumbersome. And then the other round two of adaptive testing is when they do not select a regimen that is recommended and they want to build their own. We want to be able to test that scenario out so that when they go through that process to see if even though they haven't done the order yet, they're going to say, no, I don't want to use any of those. Now I'm going to build my order and go into the order sign. And then the round three testing is regression testing to check if the member and physician maybe site is not found, or if the member is not found on the payer side, if they're not covered. The cases where it's a pediatric member and we always approve a pediatric cancer regimen, we want to test out of network sites and urgent requests. So those are the three rounds of scenarios that we want to test through. And you can see on the bottom there's some scope where we're starting with the health plan of Cigna. The total test scenarios we have identified, there's 22 of them. We found 2 to 5 patient members that we want to test with, as well as 2 to 5 providers with US Oncology, which is our provider partner for the pilot. So early learnings and observations. This is where through the process that we've been through, we've come across a few things. First, finding some general findings. There's tremendous benefit, obviously, to the patient and provider for automating prior authorizations. Kirk proved that point earlier. The proof of concept to the pilot is advancing so that we want to commence a production pilot in early 2024. The partnerships with our technical developers, our HR vendor, our provider group have been formed to facilitate these progress. The HL7 Connectathon engagement has been proven out to be extremely helpful, and the CodeX pilot is exploring the advancement of provider treatment options to facilitate selection of covered regimens. The challenges, there are some challenges with fully executing because of the readiness of the system. So Varian, I mentioned earlier, they're on a release schedule where we're waiting for some capabilities for them to be added to their product. And it has to go through their normal release schedule because they have other business to take care of, obviously. And there's some lack of clarity on the convergence of multiple prior authorization standards. Kirk mentioned again, we're being held to the HIPAA X12 requirements. We're reconciling that with with the FHIR capabilities. And when we get into including drugs, particularly pharmacy drugs, in with our cancer regimens, we have some NCPDP considerations that we have to take care of. Specific to the CRD, there have been some challenges with the EMR that the CDS hooks are not currently widely available. For this particular pilot, I mentioned we're using order select, which is supported but will not be mandated. So we might have some challenges there with the plan of being clinical decision support driven before they enter the order. That's not a problem. We can still do the order sign CDS hook and offer an alternate recommendation, but that is a challenge that we're finding. The CDS hooks are not currently widely available in all the EMRs. Also the CodeX implementers have developed an alternate means to the CDS hooks to launch the CRD using a Smart on FHIR app, which is not normally the standard in the implementation guides. The Smart on FHIR is limited to the DTR only. And for our current solution to get through that challenge is that we're using Smart on FHIR to launch CRD as well. In the future, we wouldn't have to do that, and we would use the CDS hooks. Specific to the DTR, the implementers are really anticipating the servicing provider dependency in the workflow might not be covered. As I said, our pilot is the servicing provider is the requesting provider, but we're trying to anticipate how that would work when we're getting a referring provider and they get to a point where they have to select the site. Not something you typically want the clinician to have to do. So we're anticipating how would that follow up in an office staff following up with that. The implementers are also anticipating that there could be some API CQL related issues, CQL being that query language that extracts the data from the EMR. We have not been able to test the performance of the DTR with the CQL yet. We do know that the CQL library is being built, and that will be a library that would say if you EMR systems, this data must be stored here on your FHIR server, and payers, if you want to get that data, this is the CQL you will use. So they're building some standards there that'll make that clearer. Still don't know about the performance, and maybe I can get some lessons from Kirk. And finally, the PAS learnings. Again, the resources for prior auth are not ideal. The FHIR claims resource doesn't necessarily match prior auth data need in structure and concept completely. And it's further exacerbated by having to conform to the X12278 limited set of data that even if you use a FHIR resource, you can only use elements that are currently supported by the 278. So that's a challenge we're working through. And there's really no defined standard currently for the approval or denial decision to be written back into the EMR within the PAS process. That's still ambiguous, I think. And then the attachments. So the National Standards Division to meet the HIPAA requirements for attachments doesn't work that great with the clinical workflow defined by Vinci Implementation Guides. So we're working through trying to make sure that our questionnaires eliminate some of the need to do the subsequent clinical attachments. We're working on the FHIR PA request to be formatted in a way that makes it even better than the X12. And in the meantime, there is still conversations with policymakers to consider avoiding the X12 altogether. And with that, the what's next in our pilot for this October, we have our proof of concept 3.0, as we're calling it, that will test in a non-clinical environment with real clinicians. It will still be synthetic patient data and clinical data. We will have the questionnaires completed for the data pull and possibly some manual multiple questionnaires. And we will conduct some user surveys after that. Our goals for learning there is to make sure our questionnaires are working well, they're performing well. We want to test those 3 separate rounds of scenarios, and we want to get the feedback from the users to evaluate potential changes before the next pilot, which is targeted for the end of January in 2024. And again, we would be testing in an environment that is a non-clinical environment, again with real clinicians, synthetic data, but in this area we want to be able to get more patients and be able to have the EHR create new patients and test with that set of scenarios. And we would go through the same 3 rounds of scenarios. We would be testing with US CDI v3 at this point, and we would want real-time patient and clinical data, which in the previous scenario we're implying it wouldn't necessarily be real-time. And let me explain that a little further. Currently, the Varian EHR only updates their FHIR server overnight, and we are fully aware that that could potentially be a bad experience for a clinician. So in this, by January of 24, we're hoping that we can get that FHIR server updated real time as the EHR is being modified through real-time use with patients. Some of the things we also want to do, I mentioned earlier, we're going to move into breast cancer and medical oncology. Some of the things we're going to work on throughout the pilot is to produce a white paper. We want to continue to inform Vinci of our findings, and there's always the industry call to action, which we're saying here too. We would like to call all of you to action. And one of the things we did have, I think Sue mentioned this, we had a listening session with ONC and CMS, and we are scheduling a demo to show the current capabilities with them coming up later this year. And now I'm going to hand it back over to Jocelyn. Thank you.
That's awesome. And Ellen, if you're okay, we can go ahead and stay on your slide deck. That's our last slide for today. You're the best. Thank you. First, I just want to say just really how amazing it is to have you, sort of in a different track, in a different accelerator, sort of come and share progress points that, while you're not as far ahead as the Cambia team is, the real meaningful progress you've made with code, with partners in the market. And to me, for somebody who spent a lot of time around prior authorization, in a place where, oncology is typically sort of booted to the back of the line because it's complicated or it's really hard because it's so multi-party. So I just want to say hats off to you and the teams that you're working with to actually prove out these implementation guides within a very complex set of workflows. So thank you very much. And I think for those of us who got to see Kirk and Sue present in the past, just sort of the gravitas, I think that your storytelling and the work that you're doing shares to the progress points, I think is really, it really sort of just, punts it home. So thanks. And you're still on screen, just so you know when you flipped over. So.
Okay, yeah, I don't know what happened there.
No,
Let me go
okay.
back to.
I'm
Go back to
currently in
there.
a
There we go.
I'm currently
No,
in a fight with Teams interrupting me, so don't worry.
no, I was trying to hit the unmute button and I changed my screen accidentally. No, I was just going to say the complexity of oncology was one of the reasons we wanted to start there
Yeah.
and make sure that the implementation guides would allow us to do what we want to do in the oncology space.
I think that cues up sort of from a question perspective to me, one of the things I wanted to get at in our Q&A, which is, really you and Kirk, you on the vendor and payer side, right, with Cigna Group and Evernorth, and Kirk on the payer side, working very closely with partners in the market. What was it like, I think, doing this work alongside sort of your day-to-day existing business? And I want to think about it not just from hey, what was it like to stand up new technology and start testing with new technology, but getting the not just the technical, but the business processes to really start thinking about how to do this differently. And I'll go to Ellen first and then flip over to Kirk, if that's okay.
Yeah, for me, the timing was really good because I was also being moved into a role in enterprise architecture where we were wanting to really transform prior auth and really, Evacor's arm of Evernorth manages 105 different payers for the country, and I think we have calculated we touch probably half of the nation's population. So we really wanted to say we have the responsibility to make this better for the patients, for the providers, and so we really jumped into that whole let's be transformative space. We also had our oncology program was stood up probably 10 years ago with the same approach of saying, hey, we want to keep up on the guidelines for you and talk you through kind of a clinical decision support process to get to the prior auth. What we didn't realize 10 years ago when we did that, we were very naive in thinking the provider themselves were going to come to the portal. Nothing's further from the truth.
Right.
So we found that we were offering clinical decision support to non-clinicians, and that just wasn't effective. So Da Vinci comes along and says, hey, you have an opportunity to get in front of the clinician workflow, and then we're going, that's exactly what we need. So for me personally, it wasn't that much of a off the side of the desk. It was something that I was focused on anyway. That said, it was all done without funding. So I actually literally had someone say, don't work on that. And I said, no, I'm going to work on it anyway. But there's always the funding issues. So that for me personally, it was being rogue on the funding requests.
Well, I'm personally thankful for that because I feel like I helped drag you into this. So thank you very much. So Kirk, maybe can you talk a little bit about, because you're sitting in a much different seat in your org, right, than Ellen is, sort of, as a line developer architect inside of her team, coming at this and how Cambia approached it really from an enterprise perspective with, regions being one of your health plans. And you're still on mute if you're talking already. And I'm just going to say out loud that GoToWebinar has been super fun for all of us today. I think you've got yourself double muted, Kirk. I'm going to let you play around and figure out if you can hear yourself, and I'm going to move on to another question to Sue while we're waiting. So Sue, I think it's really important to look at, I think one of the things that you illustrated, Da Vinci has been so much in sort of the framework and content building from an implementation guide perspective, because there really were no workflows that existed for a lot of these value-based care-based workflows and prior authorization when we got started. But CodeX really started, sort of a couple of years after us with this idea of saying, how do you take M-code and get it out there in the market, in the real world? And I think I'd love to hear you talk about sort of that perspective from CodeX about why real world testing was important and getting applications working, but then also maybe take a minute to share with folks what guides you are building where you're in more green space, where other accelerators or FHIR guides don't exist yet.
Yeah, Jocelyn, thanks for that question. So actually, the origin of CodeX is partially from the folks who championed the building of MCode, and part of it was that all this effort was really spearheaded on behalf of MITRE, but really with ASCO, which is the American Society for Clinical Oncology, major cancer specialty society, and they were having a lot of difficulty in getting traction with getting buy-in from MCode in the community. And it was so CodeX was really born out of the recognition that there can be development of standards, but the value of them is really only if they're used, right, and used widely across healthcare space. And so CodeX was really designed with that end goal of impact. And so that's really the ethos and origin. In doing so, in learning in this space, it's been interesting because where we've developed in CodeX is sort of an outreach of both standards development. We've done that in radiation oncology, but then it's also not reinventing the wheel. And so where clinical and healthcare folks have really seen needs of priority pain points in clinical data sharing, such as in genomics, where there was already standards built. It's similar to cancer, where we've then developed the community to try and build the robustness in real-world testing needed in priority use cases to trigger traction adoption. Is it okay for me to just take 30 more seconds to highlight how we developed the radiation ID and what that's meant for adoption, Jocelyn?
No, I think it's a really good use case of interest for this group because it overlaps with PA so much. So.
Yeah, and so that's been a really exciting story where the radiation oncology community really felt that there was a need for development of a specification. They felt like their initial goal was really small. It was just to get that end of cancer treatment summary. And their goal was 5 years. In less than 2, we were not only able to garner with their support a larger community, develop the specification for radiation oncology for end-to-end treatment flow, and that was actually just published a month or so ago. We just released that. But in doing so, by garnering the community, we really bought in the further radiation therapy community support, including key vendors such as Varian, Electa, Research, etc. And so that was the way that we got the adoption and buy-in for having those specifications in either production or roadmap release for what we cited earlier, greater than 80% of what will reach greater than 80% of North American treatment sites. And that's the platform then and the connections that Evernorth here in championing this use case was able to leverage with Varian to make, data elements that otherwise wouldn't be accessible. So it's in this community where by doing it, we're able to leverage best practices and lessons learned and ease the pathway to real-world adoption. And one thing that is coming up, and I'm hoping our community will be ready to share by HIMSS of spring, is that this is further pushing the needle for adoption. We've had reports now that there's increasing vendors or increasing folks in industry who have adopted MCode and are starting to test it out and flex it for use. They're not ready to share yet because they see it as, for now, proprietary developments. But this may be, it's still early, but it's more accessible, than folks may realize. So being able to do this and start to reach and impact patient specifically for prior auth or other needs of care, this is something that I feel like can truly happen from watching the CodeX community.
I think there's a really important thread here that you touched on that we see across the work that we're doing, right, in these accelerators, which is, creating a place for these conversations to happen, for the party of the willing to go first. And then I think it is remarkable, right? We have some federal alignment, right, through the rules that, you and Kirk both talked about in your presentations. But on the use cases or the business problems that don't yet have that, if you get a bolus, right, enough people involved, how it really does become sort of the de facto way that folks are moving, and it creates its own momentum. And I think that we're seeing that both in the conversations I think that you guys are sharing about the progress in oncology around prior auth, but also a number of the use cases I think you've referenced and that we covered earlier in the Da Vinci side that really shows, like, if we can get smart people together to solve problems using APIs, and we can define them in a standardized way, people will pick them up and use them, which I think is one of the secret powers, right, of the accelerators. I think Kirk has returned with sound. So Kirk, can you take a hit at the sort of the business process and the technology, sort of like what did it take to get you here? Again, since you're sitting, I think, at a much different seat, sort of organizationally, to where our typical sort of participant is.
Sure. Yeah, well, first of all, I think similar to what Ellen had to share, it didn't take a lot of convincing of anyone that prior authorization is one of those processes that we're continually looking at. How can we do it better? How can we do it faster? How can we reduce costs in that process? And prior to Da Vinci and FHIR APIs, there was a lot of work that was done in the name of automation inside the four walls of regions. Right. As FHIR APIs emerged, it was really just a matter of us couching that work or that innovation as an extension of the automation that we were doing internally to extend it into the provider's system. So it's that interoperability space that we wanted to layer on top of work that was already a high priority for the business. I think, of course, the other thing that should help everyone, a couple things. Number one, I mean, this is a winning idea, whether you're a provider or a payer or a patient. I mean, it's demonstrably cheaper, better, more secure, et cetera. But if the inherent value of the work itself wasn't enough for us, this is also going to be mandated for us by the CMS. We've seen that rule, not yet finalized, but the feds are going to drag us all to FHIR API-driven exchanges, and thank goodness for that. But that should really help those of us who are passionate about this problem, but are looking for ways to get traction and funding, et cetera. Keep an eye on that. And, you know, as long as your company wants to comply with federal law, you should have a good, willing audience on your FHIR-powered prior auth initiatives.
Yeah, Kirk,
Okay.
the battle I came across there was disbelief that it would really happen because of all the previous attempts in the industry to standardize.
That's true.
And I think it's the writing is on the wall. I think people are saying, yes, it will happen.
Yeah, great point. Great point.
I think that that is frequently a conversation that happens, right? What makes this time different? And I think that, you know, Ellen, the work that you're doing and that Kirk is doing, I think is sort of breaking down sort of that legacy sort of skepticism to show that like the promise is actually there and we're executing on it. But I think that it's up to us as evangelists, right, to go out to the organizations and share that. I'm going to flip us back a little bit to more technical questions. A couple have come in while we've been talking. The first is someone is asking, Ellen and Kirk, if you want to speak to this. Ellen, you talked about this a little bit, but maybe the approach that you're using in lieu of CDS hooks being available. We definitely hear the availability of CDS hooks across a multitude of the use cases, that how fast can the right hooks get put in place, what you guys are doing ahead of that, just from a technical perspective. I think that would be helpful.
Yeah, as I mentioned, the CRD process is intended to be where well, let me back up a little. The 3 separate implementation guides were written separately because they are intended to be able to be implemented separately. But in a typical prior auth process, the CRD is where you start. Is this covered? Does it require a prior auth? So that is where the CDS hook would normally start the process, because the CRD would come back with a system action for the DTR to continue from there. As I said, the DTR was also intended to be using a Smart on FHIR app. And what we've done is we've expanded the Smart on FHIR app to launch the CRD using a button click. So there is an additional mouse click to launch than there would be with a CDS hook, but it is just one click.
That's great. And Kirk, I'm going to pivot to you just with a slightly different question because I think you're further ahead in the curve here. Today you guys are implementing with Epic, maybe a little bit of clarity around sort of what it is that you supplied from a technology perspective and what the plan is to get to, and how we think we're going to get to other EHRs as we really look to scale these solutions out into the market beyond Epic.
Sure. Yeah. So the initial development of this smart app took a lot of collaboration between really all three players here: the payer, so Regents on our side, Multicare and the clinicians, as well as the technology team at Multicare, but also Epic, who were very helpful with us in ensuring that the smart app that we built was going to achieve the objective in Multicare's Epic system. We have Epic has a lot of market share out here in the Pacific Northwest, and so as we have now been looking to expand this solution across additional providers, most of them that we're talking with are on Epic, and we've got 6 in flight right now that we're implementing this. We're working through some of the contractual hoops of that 278 exception. That's proven to be the long pole in the tent, is getting lawyers to sign something like an exception to HIPAA. They don't do that lightly. But once we are through that, the implementation costs provider side here, which is the configuration of that smart app that is in the Epic connection hub, is a days, not weeks kind of initiative. So that part goes fairly quickly. We're also getting our smart app, which being built to the smart framework. The point of that is to minimize rework as you go to deploy it into another EMR. We're in that process right now with Cerner, now Oracle, and are working through that. But I think at the same time that we are making our solution here, our smart app, available freely to providers to use with us, we're also keeping an eye as a broader community, the broader Da Vinci community, as to how do we really scale this into the future in a way that doesn't result in 50 different smart apps that providers have to work with across 50 different payers. A lot of ways to skin that cat, we think, and not least of which is the expectation we're hoping to see from the ONC side of the regulatory arm, some requirements put on the provider side to create these provider side capabilities, FHIR capabilities, in order to do the prior authorization process, right? So we don't want to be in a situation where payers are building out this capability on their side in anticipation of that CMS mandate, and we go live with that, and there's not the provider side capability to take advantage of it. Smart apps is a way to bridge to that future, but we also see, and we know this from our own Da Vinci members who are EHRs, they are working on these capabilities being available to their customers natively or with their own smart app. Those are all interesting. That would certainly help this problem. We also have TEFCA emerging, so approaches where we are taking advantage of that QHIN model. There's lots of ways to scale this, but in the immediate term, we are scaling it as quickly as we can in the ways that are available to us right now, which is smart apps, and that's going really well.
That was great, Kirk, and I love that as I was tracking extra points I wanted to make when you wrapped up, you literally went to every single one of the points I wanted to make, because I think it shows sort of the industry first sort of work that we're doing here, right? That you're hearing Kirk talk about how his colleagues at the vendor side and even Ellen and Kirk talking about how we're trying to figure out how to do this sort of pan payer and pan vendor really is about, sort of moving the industry forward so we can get that scaling done, which I think is what is incredibly unique about what we're doing here in the FHIR community, that we're really sort of putting progress first over sort of proprietary technology. With that, I'm going to thank all three of our presenters today. You guys were really outstanding. Thank you for great participation and interest. We could watch you guys sort of watching every slide turn today. And just a reminder before you exit, if you can go ahead and answer the brief survey that will launch at the end of the webinar. This information will get posted up usually by about midday tomorrow, the slides included. And we look forward to seeing you at the end of September for our next community roundtable. And as always, so thankful to see the real world progress that's happening out here in the market, really being led by remarkable teams, just getting stuff done on a daily basis. I'm so pleased to be here with all of you. Thank you. Thanks, everyone.